of Zoom, so bear with me. Whitney and I were just talking about how Zoom, a long morning, but can be a little bit mind numbing. So make sure you get up, had a chance to move your bodies and have a snack or something, because it's hard to go back to back. So feel free to go ahead and take a moment and do that. Just a couple of things about Zoom. It's really helpful for presenters to keep your video on and also just have your name on the screen how you want to be called upon, because I think it's, especially in Zoom, if we can make this interactive, I think it's so much more fun for the presenter and the audience. So that's awesome. And then if you have a question, feel free to just pause and ask. And chat, I think chat, I'm gonna try to get chat up too, because I think that's a really nice way to ask questions too. No problem if you don't have video, that's fine. Although you might want to look at the recorded version, because dermatology is pretty video centric. It's stuff you definitely want to see. All right, so my background is I am a dermatologist, but I did an internal medicine residency at UW before doing derm. And I was in my 3rd year of internal medicine residency, and I realized I didn't know any derm. And so I went back and there's a couple of resources I used to learn derm as an internal medicine resident. But why I'm interested in speaking with you guys is there's not a lot of dermatology in internal medicine residencies curriculum. I think it's really important, because studies have been done about primary care clinic settings, and 1/3 of all primary care visits for adults, dermatology is one of the is like the major problem of that visit. And for more than 50% of primary care visits, at least one dermatologic issue comes up, whether it's a rash or whether it's just something simple as, oh, by the way, I have this new spot on my arm. Do I need to worry about it? So it's really common. So if you are I know you guys are on your primary care immersion blocks, and this is coming up all the time. So what we're going to do today is just talk about the basics. We're going to touch on a couple inflammatory dermatologic problems, and really focus on how to treat them. So if you have a rash and it's on one certain part of the body, how are you going to pick the topical steroid to use that's going to be safe and also effective for your patients? So that's what we're going to focus on today. All right, so I have no conflicts of interest. And our learning objectives today are really to choose a correct topical vehicle to your therapeutic advantage, learn about topical steroids and their side effects, and then recommend an appropriate topical agent based on the location on the body where the rash is, and thinking about the side effects that could come up in those areas. Okay, so we're going to just start with a case. For these, when we go through cases, I think what I'd like you guys to do first is just to describe what you see, whether in chat or whether in person. And a little background about describing things in dermatology. The first thing that you guys want to think of is, what is the primary lesion of the rash that I'm seeing? And so there's essentially, for rashes, you have 4 options. And you can combine these in any way you see fit. But just a reminder, a macule is something that's flat. So if you close your eyes, you wouldn't be able to feel any changes. So something that's flat and smaller than a centimeter. A patch is flat and larger than a centimeter. And a papule is something that is smaller than a centimeter and raised. So if you close your eyes, you're going to feel a bump there. And a plaque is something that's larger and raised. So those are your 4 options. So when you're looking at a rash, step 1, pick one of those 4 options. Step 2 is add other descriptive terms like texture, color. Is there any other secondary changes like excoriations present? So with that started, let's just go ahead and I'll kind of open the floor to you guys and try to describe what you see here. Don't all jump at once.
Macular papular rash, that is erythematous.
Yeah, great. I agree with you. I think if you closed your eyes, I think this would feel raised. And I would say papules that are coalescing into plaques. Yep, and I think erythematous is a great term. Any other descriptive terms everybody would want to throw in there? Kim, I'm amazed. Without video, you've come up with lichenified plaques with excoriation. That's just amazing because that's what we see, and Kim doesn't have video. So I'm, oh, you can see me. All right, sweet. Oh, I get it. I can't see you, but you can see the screen. All right, well, that's all you.
But Kim is pretty amazing though.
Anyway, it's pretty amazing. I know that. So yes, this is I would describe this as an erythematous plaques with lichenification. And lichenification, Kim, do you want to tell us about lichenification?
I think it's sort of like thickened with cracks.
Yep, love it. Yeah, and I think the other thing is you can see accentuated normal skin lines, so you can see that. So this is lichenified plaques, and then there's excoriation. And the excoriations are essentially just erosions, and you were implying the cause of scratching with that. So that's great. Okay, so I really like that description. And the location is here on the antecubital fossa, and we hear that it's itchy. So what do you guys think this is?
Eczema?
Yes! Love it. Okay, you guys are all right. Okay, so we described what we see, and my working diagnosis is eczema. So you were precepting with your attending, and your attending says, great, how do you want to treat it? And these are the things that are available to you at that moment on your formulary. What are you going to choose for this site? A, B. Okay, B. All right, this I'm going to go with, I totally agree. I would use triamcinolone ointment. You're wondering, why are we using triamcinolone ointment? And that's what our talk is going to be about today. Why do we pick triamcinolone ointment? It's a correct strength for this site, and the ointment is going to help it soak in. And it's not too strong that we're going to get side effects, and it's not too weak that's going to be ineffective. So what we're going to talk through, the meat of this talk is really about how to pick a topical steroid. Okay, so first we're going to start with some basics of topical therapy. The most common topicals prescribed by dermatologists are really corticosteroids. This is the workhorse of what we have on our quiver. We prescribe a fair amount of antifungals, less antibacterials, and the topical agents for acne. But corticosteroids, you're not going to do a day on a derm rotation where you don't prescribe multiple topical steroids. So I want you guys to really feel comfortable knowing which ones to prescribe. First thing I want to talk about is what factors affect absorption of topical agents into the skin. Why don't you guys throw some out there? If you're thinking about how am I going to get this medicine into the skin, what variables are you going to think about? How thin the skin is, that's perfect. Yep, or conversely thick. You can think of a plaque of psoriasis, and you can kind of intuitively know that it's going to be hard to get medicine into that really thick plaque. Or if it's very thin, it's going to be absorbed a lot easier. Anybody else want to throw out some other things? Location, yeah. And John, a little bit more about location. So why does location matter when you're thinking about how are you going to get a medicine into the skin? Think like a chemist.
I think I don't know. I just know that you're not supposed to use certain types of topicals at certain strengths that are on the face or whatever.
Why not? Why not?
Probably because stuff is around the face that you don't want. I don't know. I have no idea the answer.
Okay, that's what we're gonna get to. Yep, you are exactly where you should be. The skin is different at a different location. Yes, I totally agree. So when you think of the face, it is a lot thinner and a lot more prone to acne and rosacea, which can be side effects with topical steroids. When you think of skin that's underneath the armpit or in the groin, that's a skin-on-skin site, so things are affected differently there. As opposed to like the knee, there's no skin on skin at that area. So things to think about, is the skin hydrated? The more hydrated the skin is, the better the medicine is going to get into the skin. The skin integrity, think of a really thick plaque. It's going to be hard to get medicine deep in there as opposed to kind of a thin broken down area. Temperature, when the skin's warm, it absorbs things more. And vehicle, and what vehicle gets to is is the medicine in a solution? Is it in a cream? Is it in a lotion? Or is it in a gel? We'll talk more about those, but the vehicle really means what what is the medicine sitting in? And then occlusion. Occlusion is one trick that we use frequently to our advantage. So what that means is you put the medicine on the skin and then you wrap it with something or put tape over it, basically really prevent evaporation. And it really just helps the medicine soak in if you have it covered with something. This is a sauna suit. I don't know if you guys have ever seen one of these, but we use these frequently in somebody with extensive inflammatory dermatosis. So eczema, psoriasis are great examples. We often use this when they're admitted in the hospital, and there's a couple days when we're trying to figure out the diagnosis and what topical or what systemic medicines to put them on. This looks great. How you use it is you have them smeared head to toe in a topical steroid that's appropriate to what their diagnosis or we think it is. And then they wear this 24/7. And what this is essentially it's like a sweatsuit from the 1980s that wrestlers used to wear when they wanted to drop weight. So you're really hot and damp in it. And that's kind of a good thing to think about when you're thinking about how to get medicine in the skin. If it's hot and damp and occluded, you're going to get it in really well. So people with head to toe psoriasis can put these on and within a couple of days, they're remarkably better. It's not a long-term solution. You don't want to wear a sweatsuit the rest of your life, but it's a great short-term solution when you're in the hospital. So when you're thinking about vehicles, the options you have here are ointments, creams, lotions, solution sprays, and gels. And I have these ranked in order from the most hydrophobic to hydrophilic. So ointments, think of just Vaseline, and that's essentially just pure lipid. It's petrolatum jelly, and it's just like very lipid rich. And when you think of at the bottom of the spectrum, a gel, it's very water rich. So those are hydrophilic. When you think of the skin, things that are lipid rich absorb really easily, and gels, things that are water rich, absorb less well. This is kind of like your basic chemistry that I know you guys haven't thought about for a while, but it's something that we use frequently in dermatology, thinking about what's going to go into the skin. And that's just because what is the skin made of? The skin is essentially a whole bunch of lipids acting as mortar, holding skin cells together. So it's basically lipid and skin cells. And so ointments and medicines within them get into the skin very well. Let's see. And then occlusive tape gets in the skin really well because it uses also the principle of occlusion. So the more occlusive the vehicle and the more lipid rich, the stronger it is. And the strength varies from top to bottom. So things that are occlusive and lipid rich. A couple of things to know is the potency really varies by vehicle. So for example, triamcinolone ointment of the same percentage is stronger than triamcinolone in a gel form. So we often use that to our advantage. Dermatologists almost always prescribe ointments just because they're stronger and they get on the skin. I hardly ever prescribe gels. So ointment is the way to go to unless there's some reason not to. Often we end up using ointments not on the scalp just because people don't want to have a greasy scalp. So we often use an oil solution, and on the face, people don't really like to have things greasy on their face. Same thing for intertriginous areas, so skin on skin areas. We often will use like a cream in those areas just because patients often just won't be compliant with therapy if they don't like the way their skin feels, which is understandable. So steroids are grouped in 7 different classes. Group 1 is the super potent, and the group 7 is the least potent. And this is just a little bit of background information. You don't have to memorize this. So I talked about how topical triamcinolone in an ointment is stronger than triamcinolone in a gel. One thing to take note of is when you're talking about the same steroid, you can compare potency by the percentage. So intuitively, triamcinolone 0.1% is stronger than triamcinolone 0.025%. That makes sense. It's a bigger number. But when you're comparing a different topical steroid to each other, you can't look at the percentage. So I think you're probably realizing that this might require a little bit of memorization. So hydrocortisone 2.5%, even though it's a bigger percentage, is much weaker than clobetasol. So you got to have a couple steroids that you're familiar with. So your options are to memorize this large table, or you can memorize something that's much abbreviated like this. This is topical steroids. A couple of things to note is we use the strongest topical steroids on the hands. Hands are a great example of a spot that they can use a really high potency topical steroid for a long time and not get into any troubles. You can see on the right this don't column. So when would you not use this topical steroid? Definitely don't use high potency topical steroids on the face, groin, or axilla, and also if the patient has fungus. And that's kind of the same for any topical steroid. And what I mean by fungus is a dermatophyte infection of the skin that's going to make the tinea worse. And those are all tinea capitis, anything like that. Just a second, there we go. My power charging is being funny. Okay, and then looking here at the bottom, or even further down, that classes 2 and 4 are examples of ones that you can use on the body. I wouldn't use these for long term on the face or groin, maybe a day or two, that would be okay, but not long term. And then hydrocortisone 2.5% is really the workhorse for us for things that are on the face or intertriginous areas. If you note over here in the don't column, we have a don't put it on the hands. That's the only reason that is it's not going to be effective. So frequently in dermatology, we see people with like a hand dermatitis, and on the referral it would say refractory to topical steroids. And you're like, what topical steroid did you use? And it's like, I used triamcinolone cream twice daily for 3 days. And you're like, and it didn't get better. Yeah, so that's example of prescribing something that just, it's really low potency. It's not going to work for that area. So, all right. So the two major ones we touched on are betamethasone and hydrocortisone. This is what I would memorize. I think you only really need to know 3 topical steroids. So for face or intertriginous areas such as the armpit or groin, just have hydrocortisone 2.5% ointment in your head. You can also use a cream if patients prefer. For the body, we almost always use triamcinolone or something equivalent. So that's triamcinolone 0.1%. And then for the hands, feet, or scalp, those are all areas that can tolerate a very high potency topical steroid and also often necessitate a high potency topical steroid because the skin is thicker there and they're very resistant to side effects. So we often always use a really high potency steroid like betamethasone at those sites. Okay, any questions about the vehicle, things to think about when you're getting a topical steroid in the skin, or the 3 to really memorize and have in your quiver? All right, I'm not hearing anything. Good. Okay, now we're going to touch on some side effects of topical steroids. So things that we've talked about previously is how the face and intertriginous areas are a lot more sensitive to side effects from topical steroids. What do you guys see here? Do you guys want to describe what we're looking at? Okay, one of those 4 words: patch, macule, plaque, papule. You have a 25% chance of being right. Okay. I think Kim has done a derm rotation before. Hi, Kim. Yep, exactly. I like this. This is I agree with the patch, and I also agree you could use macule. I think some of them are smaller than a centimeter, but I very much like patch. And hypopigmented is pointed out too. That's a great description. And what hypopigmented means is just lighter than the surrounding skin. And then what color are you guys looking at? We see lighter than the surrounding skin, so that's kind of a white. And then there's some darker areas. What colors are those? As an aside, when you're thinking about describing color, I would actually just recommend starting with sort of the colors in the crayon box and not try to infer causality to it. Often people want to say like, There's melanosis there, and melanosis is really getting at like the fact that there's melanocytes in the skin, and that's not always the case. So I would just start with colors like, is it red? Is it brown? Is it purple? Yeah, good. Okay. All right. So Kim and Lauren, I love those. I think some of these are kind of violacious, and I also like the red-brown description. So from our description, you guys can infer what things make the skin reddish brown or purple. What could, if you were to do a biopsy, what would be causing that color? What do you think would be seen on the biopsy? Bruising. Yes, Alex, exactly right. Yep. So this, what we guys are looking at is blood ecchymoses. Yep. And what we're looking at here is this is somebody who's used a high potency topical steroid on the face for a prolonged period. And what you get with that is you get atrophy of the epidermis and dermis. So the blood vessels are a lot more easily exposed to the skin. They don't have the overlying collagen. And you often get ecchymoses in areas where you wouldn't normally get ecchymoses. The hypopigmentation is a side effect of the topical steroids too. And there's also, I think, a little bit more easily visible blood vessels. So those are called telangiectasias. Oops. Okay, yeah, and pigment change. So lighter than the surrounding skin, the hypopigmentation. So all examples of things that you can see using a high potency steroid on the face. This is an example of steroid-induced rosacea. That's also one of the reasons why we don't use high-potency topical steroids on the face. Is they cause rosacea, and they can also cause or worsen acne on the face. That's only a side effect that's associated with the face. It doesn't really happen if you're going to put steroids elsewhere. Also, I think you guys can appreciate the reddish brown to black ecchymoses here. Again, an example of atrophy. And also I think you can probably appreciate on the cheek, there's a little bit more visible telangiectasias. So all examples of things that are side effects from using steroids on the face. As an aside, both of the two pictures that we just saw, if you were to stop using the topical steroid, the skin would return to normal within probably a matter of weeks. So the things that we have seen so far are transient, and they're not permanent. This, what are we looking at here? What's the medical term for what we're looking at? Colloquially known as stretch marks. Striae. Yep. Stria 1, striae plural. So this is an example of somebody who's used high potency topical steroids in the groin. And striae is one of the only side effects of topical steroids that's permanent. So this is not going to come back. Everything else that we're looking at today is transient. This is permanent. So people are understandably kind of annoyed when they get side effects of striae. And that is pretty specific to the armpits and groin, which is skin that is very prone to developing striae. Does skin atrophy go away? It does. It takes some time because you essentially have to rebuild the collagen, but it will probably go away in a matter of weeks, kind of like weeks to months, but it will go back to normal. The easy bruising is going to resolve in the same time period, so will acne and rosacea. So those aren't permanent, but it just takes time. So side effects of topical steroids. The most common error is really prescribing too weak of topical steroid. I gave you guys an example of hydrocortisone used on the hands. It's just not going to work for like a hand dermatitis. The skin is very thick. And also hydrocortisone 1% for the body. Frequently people buy that over the counter, and it's just not very effective. So that's actually the most common error, I would say, is just not selecting one that's strong enough. And then, as we talked about, side effects of topical steroids are relatively rare, and most are reversible. So I think I want you guys to go forth and prescribe and not be too concerned about causing side effects. All right, so now we're going to do some cases. And we're going to talk about, one, what's the diagnosis, and two, what is the appropriate topical steroid for that certain skin disorder. Who wants to start by describing what they see here?
Yeah, I'll try
Yeah.
to redeem myself.
Great.
These kind of like large areas of hypopigmented patches, like
Yeah.
around the scalp area, as well
Perfect.
as in the eyebrows as well.
Awesome. That's exactly how I would describe that. Hypopigmented, maybe some small macules and patches. Yep, that's great. So, is it raised? I think you can infer, looking at the way kind of how the light is hitting. It looks flat to me. That's what I would suggest. It's flat. What do you guys think this is? Tinea
Tinea.
capitis. That's on the differential. Subderm, love it. Okay, those of you who thought subderm is correct, I think things that differentiate this from tinea capitis is the really lack of scale. I don't think I see any scale. I think these are hypopigmented, but I don't think any scale. Tam and Kim, what tipped you guys off to seborrheic dermatitis?
I think for me, the location, usually scalp area, eyebrows.
Yes.
That it's patchy.
Yes, I totally agree. How do you guys know this isn't vitiligo?
I actually thought about that.
Yeah, not without pigment. Yes. Yeah. Yep, I totally agree with that. So this is, I think it's important to see this is hypopigmented, not depigmented. So I think that's why vitiligo really wasn't on the differential. And if there's ever any question of hypo versus depigmented, getting a Woods lamp out and kind of shining it in the dark on the area can really help you, because things that are depigmented will just glow with the Woods lamp. Things that are hypopigmented will kind of fade. So that's a good trick. But yeah, I totally agree. This looks like seborrheic dermatitis. And also the other clue is the scalp is involved too. It's just, we can't see a lot of the scalp, but that's a great location of it. All right, how should we treat this?
I have one quick question. Is seborrheic dermatitis itchy too? Is it pruritic?
Yeah, it's usually itchy, yeah. Yep. Yeah, so how do you guys treat this? Have you guys come across this already in primary care clinics? And if you haven't, ketoconazole or steroid? Yes, I like that. Okay. Let me get here. Retinoids. You know, Andy, I have not heard anybody treat seborrheic dermatitis with retinoids. Those are typically reserved for acne. All right, a reasonable topical steroid for this rash might be, okay, what do you guys want to recommend? I heard somebody's recommend a steroid. What potency? 6. Like it. Like it. Yeah, I think 6. I would do 6. A couple other considerations. Folks with slightly darker skin tones or have more melanin in their skin, you want to be pretty conservative when you're prescribing a topical steroid, because they can get more hypopigmentation as a side effect. So I think that all kind of pushes you towards 6 in this case. Here's another picture of somebody with seborrheic dermatitis. This is a more florid example. So things to see here, kind of erythematous. And I think this is this is so inflammatory that it's almost plaques, and there's more obvious scale. The picture that we were just looking at, I think the scale, it maybe isn't even obvious, but very subtle. And this is a florid example of seborrheic dermatitis, erythematous scaly plaques. Notice the distribution. The medial cheeks, often it's in the nasolabial folds and the eyebrows, and I bet if you looked in a scalp and beard area, it'd be pretty significant there too. All right, so treatment of seborrheic dermatitis. We all kind of decided that a relatively mild topical steroid such as hydrocortisone cream, you can use that twice daily for the areas that are affected on the face. And, you know, honestly, the picture, the person we looked at, she could use that twice daily for a couple months and not really run into trouble with that. I wouldn't have her put it on it twice daily for the end of time. But I would say if she uses it twice daily in addition to ketoconazole shampoo, she'll be able to just use it as needed after that. So what I like to do is use ketoconazole shampoo, and that's just an antifungal shampoo on the scalp and the face. You want to treat the scalp even if it's not involved by exam, because that's sort of the reservoir site. And why ketoconazole shampoo works is the pathogenesis of seborrheic dermatitis is just sort of an exuberant growth of Malvasia furfur. So that's normal skin flora. So all of us have that on their skin if we were to do a swab. And people with seborrheic dermatitis, for some reason, they just get an inflammatory reaction to it. Sometimes they have more Malvasia than other folks, but mostly it's just how their immune system reacts to it. So the ketoconazole shampoo really treats the kind of Malvasia, the fungus that's there, and then hydrocortisone cream helps inflammation. So this is something we frequently do for seborrheic dermatitis. All right. Any questions about sebderm? If you guys haven't seen it, it has seen you, I'm sure. It has a prevalence of like 20% or 25%. What does dandruff shampoo have in it? Usually selenium sulfide is the active ingredient in that. You can actually get ketoconazole over the counter too. So ketoconazole is available in some over the counter shampoos. I think it's a 1%. It's essentially harmless. There's no problem in having it over the counter. But usually it's selenium sulfide. Selenium sulfide works fine too. If patients are already using an anti-dandruff shampoo over the counter, I could just tell them to continue it because it works fine as well. Okay, next patient. This is a 35-year-old healthcare worker, one of your colleagues, and she comes in with her hands looking like this. Who wants to describe what they see? Anybody? Anybody who hasn't described anything yet, now's your chance. You have a 1 out of 4 chance of being right when you pick one of those 4: papilla, patch, macule. Let's start with those first. Who hasn't spoken? Gabrielle, Jordan, want to take a stab? Marina, patches of hyperpigmentation on the backs of hands and wrists. Yeah, I think the location is right. I agree it's hyperpigmented. Marina, if you close your eyes and ran your hands over the areas of affected skin, could you feel a difference from the normal surrounding skin, do you think? I think yes.
It's hard to tell from the picture, but maybe.
Yeah. So I think these are plaques. And what are some other descriptive words? So these are plaques. I think they're hyperpigmented. There might be a little bit of erythema. What's some other things that are notable about these? They're dry. Yeah. And when you mean dry, Andy, that's great. When you mean dry, what are we looking at? Lichenification? Yep, lichenified like that. Dry and scaly. I think scaly is kind of what you're getting at, Andy, with dry. So I would say these are thick plaques that are erythematous. You can see on the wrist, on the right medial wrist, that there's some erythema there. I think there's some hyperpigmentation. These are also thick, scaly, and lichenified. Do you guys think this is acute, like it started yesterday, or do you think it's chronic, that it's been going on for a couple weeks or more? Chronic, yeah. Why do you think it's chronic? What tells you that? Andy or Dijon, what tells you it's chronic? You're right. Why? Why do you think that? Old and new lesions. Yeah. Yep. The lichenification. Yeah. 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 Those are all right. Those are all right. So if this was acute, I think what we'd see is we would see a lot of erythema, much more erythema, and we'd see edema. So she'd have swelling, and she'd also have probably little small vesicles on the hands. And for chronic hand dermatitis, you get to this process. This is an ongoing process. Yeah, so I already told you this is a hand dermatitis. And the differential of a hand dermatitis, it's often an allergy, a contact dermatitis, or it's related to an irritant process. And the other things to think about are psoriasis of the hands can look like this, and also just plain out atopic dermatitis. Adults frequently present later in life with atopic dermatitis, and they didn't necessarily have to have eczema as a baby. So this could be just adult onset atopic dermatitis. Lauren is wondering, could this be latex? Yeah, I think it's one of the things on the possible differential. I think you're going off of the healthcare worker. What questions do you guys want to ask her to kind of figure out what could be causing this dermatitis? So we have a differential, and how do you narrow that down? And that's based on history. Washing your hands a lot. Love it. Okay, I like it. So you guys are getting at, I think intuitively, you know, or you have an idea that the most frequent cause of hand dermatitis is actually irritant dermatitis from soap and water. So dermatologists are seeing tons of people in the era of COVID whose hands look like this, and that's just because people are much more vigilant about hand washing and doing scrubbing and using kind of harsher products on their hands. So this is often not an allergy. It's just the hands are getting ripped up from hand washing, and this is kind of the chronic effects of it. You definitely want to take an exposure history. Some things that can help you figure out if it's related to your job or not is if you go on vacation or when you take time off from work, what happens with your dermatitis, or any other symptoms that you're getting at. And then psoriasis, Tam, I think that's a great idea. Psoriasis versus eczema, you also want to ask if it's in other areas. Although that's not always helpful, because sometimes you can have just psoriasis of the hands or just atopic dermatitis of the hands. I think that would be less usual, so that's a great question. Yeah. All right, so this is a hand dermatitis, and I think statistically the most common cause right now is just soap and water. Okay, so how would you guys want to treat this? What would you recommend? Yeah. Yep, class 1 ointment. Love it, love it, love it. Okay, everybody's on the same page. So I think the one to remember is betamethasone dipropionate augmented ointment. That's the really high potency one. One little trick that we use often for patients with hand dermatitis who are just not getting better is to have them put the betamethasone on their hands and then at night sleep with a white cotton glove. The cotton is because it's not going to get wet and macerated in there. Now, if they're wearing a nitrile glove for long periods of time, that can actually worsen a hand irritant dermatitis because it's just wet. So using a cotton glove, it provides occlusion, but you don't get the maceration. So that's a little trick that you can use. Just betamethasone and wear gloves. And then also it's really important to take a careful history of how they're caring for their skin. What are they coming in contact to? Do they have a history of atopic dermatitis? What do you do with your hands in the day? Any unusual hobbies that could clue you into a contact dermatitis? And then for everybody, and you guys will see this a lot right now due to COVID, things really recommend to keep hand dermatitis at bay is, of course, you have to wash your hands, after you go to the bathroom, before you eat, etc. But I think other times you can use Purell. I think it's actually less harmful than soap and water in terms of a hand dermatitis. And then as soon as you're done washing your hands, pat dry and just Vaseline all over your hands. I recommend patients with hand dermatitis to just keep some Vaseline in their pocket and just smear them after every time they wash their hands. And then at night use the betamethasone with gloves, but this is really common right now. Okay, going on to our next case. I want to check my time here. Okay, all right, we're doing okay. Hold on a sec, let me get the slideshow back. Okay, this is a 60-year-old woman who has a rash that's been present for about 2 months. No pain, but is mildly itchy. And who wants to describe what you see? Scaly plaque, love it. All right, yeah. I think erythematous scaly plaque, there are things that are interesting is confluent. Yep, that's all great. What do you guys think this is? Throw some things out there. Here's some interesting things to consider in your differential diagnosis. Stasis. All right, so I totally agree. What clues you guys into this? Why is it stasis, for example, and not a contact dermatitis? Or why is it not tinea or cellulitis? Location, okay. Yep, it's on the medial lower legs. That's the most common. How do you know it's not tinea corporis? Can you have bilateral tinea corporis? Yes. Usually not red. Yeah. I think the other thing is it's not annular. Often in tinea you have an annular scale. Yep, that's right. And then, so a little background on venous stasis. It's incredibly common. What we think the pathogenesis is usually folks have kind of venous pooling in the lower extremities, and the most usually it's because there's some mild obstruction of the large veins in the thigh, and the most common cause of that is obesity. So there's something about obesity and sitting that you're just not getting good blood return. You know, obviously, like if you have heart failure, that would contribute to this, or kidney failure, or liver disease. But the most common cause in the United States is just kind of overweight and sitting. And then what happens is in the lower legs, why you get a rash is you get with edema, you often get little leaks in the skin. And then the theory is when the skin starts to break down, you have just normal skin flora that gets in those cracks and causes an inflammatory response. And so it looks very inflammatory. You have a lot of erythema there, and you also have the scale and weeping. So how do we treat it? Oops, here's some more pictures of the similar process on somebody with slightly more melanin in their skin. All right, so here's our treatment options. Antibiotics, compression wraps, antifungals. What do you want to do? C. All right, want to do corticosteroid, elevation, compression? Yes. All right, so how do you treat stasis dermatitis? When you think about the pathogenesis, it kind of clues you into how you treat it. Number one is you want to get the edema out. So elevate the legs. And honestly, that's really hard for people to do over prolonged periods of time. You have to get up and walk around the house and go to the bathroom and cook and etc. So compression therapy is incredibly important. I'll talk a little bit more about how to do that. But also for the inflammation, you want to have some topical steroids to treat it with, and that will really help the itch. And also having sort of the ointment or cream that will really help the cracks seal up. Just a little bit of grease on the skin is going to help the cracks heal up. So really a combination of compression and topical steroids. And class 3, triamcinolone is the one you want to think of here. So compression wraps is, I think, really the best way to treat this, especially in the acute setting. So if this woman were to walk into your office, what I would do is just smear with triamcinolone, a really thick amount, and then take a Coban or Comprelin type wrap. Start at the toe and gently wrap. You don't want to do with too much strength, but very gentle. You don't want to cut off circulation, but enough to just a little bit of a compression, and really wrap up all the way to the knee. And the reason why you want to start with this and not compression hose is compression hose are great to use when the patient is kind of in their chronic baseline leg size. But when they have acute venous stasis, usually they're acutely swollen. And if they were to get hose that are measured to that diameter of the leg, once the swelling goes down, they're going to be too loose. So I would say start with this, do the triamcinolone compression wraps for about a week. And then once their leg is kind of back to their normal size, they don't have all that acute edema, then you can get a hose. Those of you who have a primary care clinic at the VA, yeah, Kim, we usually do ABIs before we do compression. That's really easy to do. It's an in-office thing. The reason you do that is it's bad form to compress somebody who has pretty significant peripheral vascular disease. Those of you who are at the VA, you can actually order compression hose, and your patients will go down to prosthetics and they'll get measured for them. So they can have like this really nice custom measured compression hose. So I would say probably the majority of our veterans could use some compression hose. So definitely, if you're at the VA, take advantage of that. It's a great service. All right, this is our last case for today. Who wants to describe what we're looking at? Macule, papule, plaque, patch.
Say erythematous, scaly patches or plaques, excuse me, with
Yeah.
like white kind of scales in some areas.
Love it. That's perfect. Great job. Yeah. Yep, that's exactly what that is. So, and also a couple of things is it's very sharply demarcated as compared to other processes. So sharply demarcated, I would say it's a thick erythematous plaque with kind of silvery to white scale. What do you guys think this is? Psoriasis. Yes, exactly right. Yeah, more pictures of psoriasis. You guys already got to that. And I'm just going to show you a lot of pictures, a handful of pictures of psoriasis. Very sharply demarcated. The classic locations are elbows, knees, but it can be everywhere. It has a predilection for the belly button and also the gluteal cleft. It can be kind of varying shades. If it's acute, usually it's kind of orange or red. And then when it's more chronic, it's often thicker and has more whitish scale. And it can be really head to toe. The areas that it often spares is the face, but it can be really essentially everywhere else on the body. But the face is unusual. Has a predilection for the low back. It can be kind of larger or smaller plaques. All these are very well demarcated. And here's an example of a plaque that's chronic, probably hasn't any treatment for years. And you can see like the really thick white scale. It's common on the scalp too. Typically we treat that just like seborrheic dermatitis on the scalp. So ketoconazole plus a topical steroid. And then it has pretty characteristic nail findings. Does anybody know the term for this nail finding when the plate separates from the bed? There's a specific medical term for this. This is like derm for 500 points. Dun, 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 dun. This is onycholysis. Pretty characteristic finding in psoriasis. And then the other common nail finding in psoriasis is nail pitting. So that's that here. Nail psoriasis can slightly increase the risk 2 to 3-fold of psoriatic arthritis. All patients are at risk for getting psoriatic arthritis, but if you see it on psoriasis in the nails, that's slightly higher risk than other folks with psoriasis. Psoriasis on the hands can be really challenging for people to live with. There's people have a lot of stigma with issues on the hands. So often folks report that like they can't really work with their hands like this, and that's pretty understandable. This is a guttate variety of psoriasis. Guttate means drop or raindrop. So when you guys are writing drips in the ICU, when you do GTT, that is drop. So you're doing drops. This is raindrops. Guttate psoriasis. Looks like little raindrops. Okay, how would you guys treat this? On the knees and elbows. B. Yeah. All right. So we're doing a class 1 ointment. Couldn't agree more. Couldn't agree more. And the one I usually go to is just because I only want to keep 3 in my mind is really betamethasone. Often what we do in psoriasis, we use betamethasone Monday through Friday and then calcipotriene ointments on the weekends. The only reason to do that is it prevents tachyphylaxis. So if they were to use a high potency topical steroid all day, every day, eventually it'd be slightly less effective. So if you have them use a non-topical steroid like calcipotriene, which is a vitamin D analog, take a break, and then when they restart the betamethasone, that's a little bit more effective. So yeah. All right, and then if it's groin involvement, then hydrocortisone ointment would be the one to use. You don't want to do a too high potency steroid there. All right, so that is the last case I have. Just a little bit of more plug-in if you want to do more derm. We have specialty rotations that internal medicine residents often do. I know you guys have a endoderm block. You end up rotating at Harborview. And we also have a derm onc rotation at the SCCA in Roosevelt, so that's a great rotation. And then lastly, I want you guys to, if you're interested in derm, to know about the basic dermatology curriculum. The American Academy of Dermatology puts that out. It's free. When you log in, you have to create a username, but it's free. And this is a screenshot of the entrance to the curriculum. And basically what it is for, they have these series of online modules. I think they can have it arranged in 2 to 4 week sections. But you just go through and do these online modules, and they're great. They're case-based, they're fun. And doing these as a third-year internal medicine resident, I learned a ton. So if you do these, you're going to know probably as much or more as your internal medicine attendings. They're really, really good. My recommendation is while you're on your primary care blocks, to just put yourself on a schedule and work through some of these, especially those that are interested in derm. They're really fun. Your patients are going to really appreciate it because you're going to see a lot of derm in primary care. And that's all I got. Questions, comments?
So you said we just have to create a membership for that?
It's not a membership. You just have to log in, and it's free.
Okay.
Let me go up to the site. If you just Google AAD Basic Derm Curriculum, you'll see that. And I think to download the modules, you have to have a member name, but it's free, and I don't know. I think they just use it to probably send you spam. But it's free and open to everybody, so it's really fun. Any other questions? You guys are also welcome to email me or any way to touch base. But thank you very much for taking time today. It was really fun, and I appreciate the opportunity. And come join us in derm. We love having internists, so come join us. All right, have a good